Go ahead.
I am going to present a case on multivalvular heart disease. My patient is 37-year-old Hindu female housewife. She had history of recurrent joint pain involving large joints of upper and lower limb since 8 years of age. And that pain was relieved on taking some oral medication. She was on injection Penidior given on buttock on monthly basis since 8 years of age. Despite the joint pain recurred on and off till adolescence, at around 15 years of age, she developed gradually progressive exertional shortness of breath. Initially, it occurred with activity like cycling, then progressively it evolved to occur on the regular daily activities. And she had a history of 2 to 3 episodes of waking up from sleep at night with associated cough and shortness of breath during that period. The patient was diagnosed of having some heart problem for which she was advised some medicine beside injection Penidior. She required few hospitalization during that period, even after taking those oral medication. And finally, at the age of 19 years, she was admitted and operated in CTVS Department of Medical College Hospital. After 1 month of hospital stay, she was discharged on oral medication after improvement. According to previous operative note, operation was done under cardiopulmonary bypass and some aortic and mitral valve repair was done. Nothing more detail of this surgery could not be elicited, could not be found in their discharge record. After operation, she was symptom free and continued her studies. She was married at 25 years of age and then she gave birth to a male child at 26 years of age at Medical College Hospital, Kolkata by LSCS. During late pregnancy and following delivery, there was a history of shortness of breath which was controlled with adjustment of oral medications. Then from 30 years of age, she started developing palpitation on exertion. It got precipitated on more than ordinary physical activity and subsided gradually on taking rest. It was also associated with mild exertion of shortness of breath. Then after 1 year of age in 2016, she was admitted with sudden onset left-sided hemiparesis, which gradually improved during hospital stay to near normal state. Now the patient was admitted in our hospital with history of dyspnea on exertion, persistent palpitation which has increased in the last 2 to 3 months. At admission, she had symptom even at rest, and there was associated pedal edema. After admission, symptoms have been controlled with oral and IV medication. There is no history of diabetes, hypertension, photosensitivity, oral ulcer, menstrual abnormalities, family history of similar illness, or premature ASCVD.
Basically, wait, hold on. So in the history, you already know that she has valvular heart disease. So I don't think you're considering any differential diagnosis besides rheumatic heart disease, or you're still considering some differential diagnosis.
They have to give a summary of history.
Okay, summarize before going to the general examination. It's a rather long history, so just summarize for Dr. Justin.
This patient has a long history spanning since the early childhood when she was 8 year of age. At the 8 years, she gives a history of multiple joint pain followed by diagnosis of some heart disease.
History, doctor. It is not a repeat history. It is a summary evaluation of a history.
What Dr. Justin is asking, tell us the flow of events which you think. What happened at 8 years? What happened at the age of 20 years when she was operated?
Symptoms and why is she
like that?
Okay. At 8 years of age, she had a attack of rheumatic fever, and after that, she was advised. She recovered from that, but she kept on having recurrence. She was put on the secondary prophylaxis on injection Penidior, but she kept on having recurrence.
Why do you think she continued to have it?
Yeah, doctor, we'll come to the after surgery at the age of 19, she was operated.
Yes,
From
sir.
that time onwards, now you can tell why is she here? What is she having from the symptoms?
After 19 year of age, sir.
Yeah, after her surgery, she was
Hmm.
fine till 25 years of age.
Hmm.
Now she is with you with symptoms. If you evaluate her symptom, what is the
Huh.
reason she is with you?
Sir, after 19 year of age, sir, till 25 year of age, she was symptom free. And in the late pregnancy, she started having symptoms. Uh, then the she complained of palpitation and dyspnea on exertion. So that may be due to the she might be having she was having valvular heart disease, and that due to the pregnancy physiological changes, the severity increased and she became symptomatic. And and at
What is the
Now,
percentile of
now,
The
right heart
severity
valve?
of the, sorry.
What is the
yeah, please,
percentile?
yeah,
Yeah,
please.
you need to say, whether the patient has a right heart disease or a left heart disease or outflow disease or an inflow
huh,
disease. Why is she
sir,
now? Evaluate
sir,
his symptoms.
considering her symptom of palpitation and this shortness of breath, so it's her main symptom of palpitation. So we are suspecting some volume overload of the LV, and we are suspecting some valvular heart disease in the form of aortic regurgitation or the mitral regurgitation.
What surgery do you think was done at the age of 19 years?
Okay, sir.
What
Since
surgery do you think by the history, not by the records?
Yes, sir. By the history, I think that the patient was giving the history of exertional dyspnea before 19 year of age. So it
So
might be
what
the
surgery? Yeah.
mitral valve. It was open commissurectomy for the mitral stenosis because he was giving history of dyspnea on exertion, and aortic valve in the form. I think that it associated aortic valve disease could be either in the form of aortic regurgitation. So might be aortic leaflet plication was done at that time.
Do you think it is a mitral commissurectomy plus some kind of aortic repair at
Yes, sir.
19, because of which she remained symptom free till the age of 25 when she got pregnant? Now,
Yes,
during pregnancy, why do you think her symptoms got aggravated?
yes, sir.
Did
During
she
pregnancy,
progress on the mitral stenosis part over these 5 years?
huh, sir, during pregnancy there is a increased change in the physiological status of the patient. There is a change in the form of the increased plasma volume.
Okay, so you think that this mitral stenosis has probably sort of progressed to restenosis or some
No,
kind of
no.
increase?
Along with that, sir, am also suspecting since he is giving the history of her main symptom is palpitation. So either the mitral she has newer lesion in the form of mitral regurgitation or the aortic regurgitation.
Acha, why she had that left-sided hemiparesis?
Sir, it can be due to the some supraventricular arrhythmia in the form of the atrial fibrillation, which is quite common in patient with the mitral stenosis or in a mitral stenosis patient.
Okay, Dr. Ketkar, you want to ask something? You said.
No, is it usual to get an aortic valve repair done also?
No, sir. It is
Rheumatic heart disease.
repair. It is not usual.
So why-
Mitral valve repair is done, but aortic valve repair is quite rare, sir.
Yeah, so
No,
rheumatic.
have you ever seen it being done? I mean,
I have yet to come across any rheumatic aortic valvular heart disease.
That's why I mentioned, sir, I did not find the details of the aortic valve repair. I am just presuming that it might be aortic
This
valve.
you found on the notes or the history?
Patient was not having complete OT records. He was having only the front page of the this her discharge slip. Over
You
there, it was
mentioned
written.
aortic valve repair, or you are
Yes,
inferring on
yes.
the basis of the patient having said something?
No, sir. It was written that aortic
It was
valve repair
written
and
aortic valve repair.
aortic valve repair and mitral valve repair both were done.
the question that I wanted to ask you: why do you think she got repeated episodes of rheumatic fever despite regular prophylaxis?
Okay, sir. Sir, there are many causes for the repeated episode of the this rheumatic fever recurrence. One is the sir inadequate this the uh, this not non-compliance with the three weekly or four weekly injection penicillin. Second is the
You
recurrence.
think 4 weekly is good enough for our country?
No, sir, it is 3 weekly. The MIC is decreased over 4 week.
So at least
So
3 times. Then in certain areas and certain lower socioeconomic groups where
yes, sir.
some recurrence is there, then you should be giving it even 2 weekly. So
Hmm.
perhaps that was not adequate.
Yes,
And despite prophylaxis, there are incidences.
incidence of that.
What is the incidence of having a recurrent episode despite regular prophylaxis on penicillin?
So on injection penicillin, it is one case per 100 year, and in on oral penicillin, it is 5 cases per 100 year.
And on sulfadiazine,
It is around 8 cases per 100 year, 8 to 10
so
cases.
sulfadiazine, it is lesser than oral penicillin. So most effective injectable penicillin, followed by
Then
sulfa, followed by oral penicillin. So the recent trend that you start giving oral penicillin
is
for fear of reaction, for fear of pain, I don't think it is a good idea. But a lot of us have started doing that.
Okay, now I have one question. What about your medication history? Wise. Now, especially in view of the hemiparesis that she had,
yes,
was she ever prescribed? Have you should write that, right? When the history of anticoagulation being given to her, you can very well elicit, no, in terms of regular blood monitoring or whatever. What medication history do you have to try and say, I am telling you she's persistently in atrial fibrillation today?
hmm.
How do you try to say yes or no, especially since she's operated at some good center, supposedly surgery done and she's been following up? So, history wise, we should be able to elicit a history of whether she has received anticoagulation at all or
Hmm.
no.
Sir, one thing we can ask about the
No, no, I'm asking whether you have asked and you think that she has in AFib by any chance. Had she developed AFib or otherwise? That
yes,
particular.
I have asked the patient about the since she was admitted with thromboembolic complication, suspected thromboembolic complication at the age of the 25 years. So I asked, and she was on oral anticoagulation therapy.
So currently taking oral anticoagulation. See, you started with a story going from 8 years of age. We are more interested as to what is happening right now to her. Right now, she doesn't have any orthopnea PND to
And
think in terms of a restenosis.
she was admitted. So she was admitted. She is admitted at 30 years old age with history of persistent palpitation and shortness of breath, sir.
Okay.
And with pedal edema. And after treatment, she improved.
No, the PND orthopnea has a negative history. I didn't notice anywhere. That's why I'm asking. We are just trying to play the Sherlock Holmes and trying to figure out whether she is open mitral commissurotomy done there or just she got a ring for mitral valve repair. And right now, whether she is in AFib or otherwise. Okay. Okay, go ahead.
But they have given the history of PND because he has mentioned the patient has 2 or 3 episodes of waking up in the night.
Oh, she has PND because I couldn't see. When you started writing about
That is said
dyspnea.
before the surgery. Before the surgery, had 2 episodes suggestive of PND, but he
PND, yeah.
has
We
PND.
have exhausted 17 minutes on history only, sir.
Okay. Go ahead, please. Examination.
Exactly. Yes.
Next slide, please. On general examination, pulse is 92 beat per minute. Irregular, high volume, no specific character.
Is
No
atrial
rate.
fibrillation.
Yes, sir.
Expected, no? From history. Go ahead.
No specific character, no radial or radiofemoral delay. All peripheral pulses are equally palpable. BP in upper limb is 106 by 50 mm of Hg, and in lower limb is 120 by 56 mm of Hg. And JBP is raised, mean JBP is raised 8 centimeter above medial end of clavicle. A wave is absent and prominent B wave, and there is VY descent. There is no cyanosis or clubbing. On chest is bilateral vesicular breathing sound, and there is no crepes, and there is a median sternotomy scar seen. On abdomen examination, liver is 2 centimeter below the costal margin, non-tender, and spleen not palpable. There is no obvious musculoskeletal abnormality. Next slide.
So on general examination, what do you think is happening to her?
Huh.
So
Sir,
we know that she has undergone some mitral valve repair of some kind, either open. So what is happening to her now on general examination?
So on general examination, from pulse, I can gather that she is having atrial fibrillation, and second is she is having high volume pulse, indicating of the increased pulse pressure. From BP, I am saying that there is a low diastolic BP and systolic BP is normal. So there is a feature of
what is Hill's sign and what is happening to her in terms of her AR?
Huh.
How significant is the AR? Is in other words I'm asking you.
Hill sign is a sign. This is the difference between the systolic BP in the lower limb and upper limb. And in severe AR, it should be more than 80 mm, 60 mm of Hg. The difference between the lower limb and upper limb systolic
So
BP.
what kind of AR does she have today? Is it on your general examination? Is that I'm asking you?
From this, sir, BP, I suspect that there is moderate amount of AR. Or
moderate AR is what you're suspecting on general examination.
Moderate or severe AR can be associated with LV dysfunction, can also present with this picture, sir.
Okay. Next, now go to the
from JVP. Okay, sir.
And JVP, do not use the word mean jugular venous pressure, doctor. Just say JVP is elevated. You don't get a mean value in JVP.
Okay, sir. Okay, sir. So,
Think is the systolic head so little in aortic regurgitation, pure aortic regurgitation or severe aortic regurgitation, you expect the blood pressure to be systolic pressure to be 150, 160. Here you have in the range of 100, 105.
Sir,
maybe due to the LV dysfunction.
Everything cannot be sort of explained by LV dysfunction.
Or sir, some proximal this valvular involvement.
So could be because of a stenotic lesion sitting somewhere, either proximally or at the valve itself.
Yes, sir.
And the Hill sign is hardly positive. I mean, just the pressure difference of about 14.
So
how is it a moderate aortic regurgitation?
Just 14, yeah.
Has Hill sign been clinically validated against catheterization pressure difference?
Yes, Hill sign is nowadays it is thought that it is a sphygmomanometric artifact.
So that we've known for long, and I don't think that we should just throw this clinical sign off and say, I mean, severity, yeah, difference will be. Obviously, we know that there is no actual difference. It's just sphygmomanometric, but we cannot throw the Hill sign off. At least that's my point of view. Okay, let's go ahead.
Next slide.
Okay.
On CVS examination, apex is in the left 6 intercostal space, 1 centimeter outside the mid-clavicular line. It is forceful and ill-sustained LV type. So there is a cardiomegaly, and there is grade 2 parasternal heave present, and there is supraesternal pulsation. And
would you like to clarify this parasternal heave further?
Sir, there is this grade 2 parasternal heave, maybe due to the pulmonary artery hypertension.
And what do you mean by here both sides bilateral carotid pulsation present? You're suspecting aortoarteritis associated for them to be absent?
Bilateral carotid pulsation, sir. In moderate to severe AR, we can find that.
But otherwise, you don't feel. You are seeing them. This is inspectory finding.
Inspectory finding.
Or is it palpatory finding that you're talking about? Forceful and sustained, and all you're saying, which means you're already talking about palpation. So you're telling present means you can feel the pulses. Or do you want to say that they are high volume there and you can feel them like,
that's what I think he wants to say that.
Carotid. So you can't just write present. You will have to present it as being that the prominent carotid pulse,
Prominent, at least you have to say prominent.
you know.
Okay.
Yeah, go ahead.
Yeah. On auscultation, S1 is variable and mostly preserved. A2 and P2, A2 is normal, P2 is loud, and there is A2 P2 split is normally audible, normal. Murmur. In apical area, I was getting a grade 3/6 pansystolic murmur and soft blowing high pitched, and it was radiating over the left axilla, and it was equally audible over the base also. The same with the no change in character of the murmur, and the murmur increased with sustained hand grip, and over the apex I also got such.
Why did you want to do a hand grip here?
Pardon, sir?
Why did you want to do a hand grip in this case?
Sir, this is to differentiate the murmur of MR from the this
No, but then
tricuspid wall, tricuspid murmur, pansystolic.
you will have a tricuspid murmur in the apical area.
No, sir. I was
No,
also
sir.
getting it at the base,
The base of what?
base of the heart. Although murmur
Base of the heart is in the second and third intercostal space, right up.
just I used to actually I was getting the murmur of the mitral regurgitation at the back also, means at the left axilla and along with the also on the base of the heart. So, sir, there was a confusion regarding if either
No, if it is a pansystolic murmur, there should be no confusion. If it is a
Okay.
long systolic murmur or injection murmur, then of course, yes, you will try to differentiate it. Okay. No point in asking you how performed the hand grip. I'm sure you did not do it. Okay, go ahead. Apical short.
there is short mid-diastolic murmur over apex, low pitched, and there was no pre-systolic accentuation. On over aortic area, there was a early diastolic murmur. Heart west over the left third intercostal space, and it was occupying around 40 to 50% of the diastole. It was high pitched and best heard in the sitting and leaning forward position with held expiration. And there was a short systolic murmur, ejection systolic murmur, which was less than 50% of the systole, and it was early peaking over the aortic area.
So I think you have described the murmurs well. At least I think we need to give him that credit that he has done a complete job as far as the description is concerned.
Now, is that it? A CVS examination. Now tell us. No, you are telling us about a parasternal heave.
Yes, sir.
So that is grade 2 or whatever. The grading is one thing. I really don't pay so much heed to the grading. I'm asking you: is that parasternal heave what you're getting? Is it a late systolic one or a systolic? Is it due to RV or is it due to the left atrium?
Sir, it is due to the RV because it was not a late systolic, it was a early systolic, and it was in the upper part of the parasternal area.
Okay. And you do not have any tricuspid regurgitation murmur, correct, in all this?
Yes, sir.
Basically, you're going to get going around, you're going to put you around in circles trying to estimate the PA pressure in this patient, correct? You got with P2 loud here, and
Yes.
even before you give us your complete diagnosis, before that we have to be very convinced about what the pulmonary artery pressure you're going to call it to be, right? There is no tricuspid regurgitation, and there is a parasternal grade 2 parasternal heave, and it is not late systolic activity that you are feeling there, correct? Yeah. So go ahead. And besides this, no other murmurs, right?
Have you got any murmur with the pulmonary area?
No, sir.
You haven't got any, ejection systolic you have over, early peaking. Nothing over the pulmonary area.
No, sir. Pulmonary area, I didn't.
Nothing. So tell us now your complete diagnosis based on this.
Next slide. So my provisional diagnosis is rheumatic heart disease, post-mitral and aortic wall repair status. There is severe MR, mild to moderate MS, moderate to severe AR, and moderate to severe PBH, and moderate PAH. There is secondary TR, atrial fibrillation with fast ventricular rate, and patient was in congestive heart failure, now in class 3 after treatment, and no evidence of infective endocarditis or recent thromboembolic event or recent rheumatic activity.
Yeah, what I am just trying to tell you is that, at least I am not very comfortable with, moderate situations. Either it is mild or it is severe. When you say moderate, it appears that you're not sure. And if you write mild to moderate and moderate to severe, you're absolutely, confused. So either it is mild or severe, or it is moderate. Okay, we'll accept that. But mild to moderate and moderate to severe, I really don't know what you're trying to tell me.
At least in exams, don't keep anything
Yeah.
ambiguous. You
Okay.
are a consultant. Whatever you say, you have to defend it. That's what it is.
Okay.
Afterwards, you may
Yeah.
go back, going to play along with the examiner. But right at the outset, don't show ambiguity. So now
Sir,
let's have the diagnosis again. It is one thing you are certain, it is severe MR.
severe
Second thing
MS.
is that whether it is mild MS or moderate MS, stick to one thing.
So it is mild MS.
Mild MS.
As
Whether
I am not
moderate AR or severe AR.
Yeah, moderate.
Some it is moderate AR, sir, because I'm not.
Moderate AR. It is not severe AR. I went to that right at the beginning. I was trying to build up on it for you. Okay. Then now again you are trying to say moderate to severe pulmonary venous hypertension. How can you ever determine that? Tell me, no. Why are you calling it moderate to severe? Be on one.
It is, sir, grade 2. It is moderate PVH, sir.
Moderate
But the
venous
see,
hypertension.
sir, after treatment, a patient presented with class 4 symptom, and after treatment, sir, she improved. Though, so now she is in moderate pulmonary venous hypertension.
So earlier she had severe PVH and now she has moderate PVH. Is that
Yes.
what you mean?
Yeah, that's possible, right? Yeah, with treatment it has come down. You've given so
Yes.
much diuretics and everything. Okay.
What is your evidence for severe MR? Sorry.
Pardon, sir?
What about
What is?
LV function? You would like to comment anything about LV function, LV dysfunction? Because you committed on a mild MS and a severe PVH. Generally, severe MR with mild MS with normal LV function will not present you with severe PVH.
Exactly.
So LV function, there is some LV dysfunction, associated LV dysfunction. Because I am
Or you want to increase your mitral stenosis severity?
no, sir. Mild stenosis is there, but there is some LV dysfunction.
So what is your
What is
evidence
your
for
evidence?
severe MR?
In this patient, sir, I am getting this cardiomegaly, and my apex is down and out, and I am not getting, sir. I am getting an MDM, sir.
But you committed
That
there
is
is a MS.
And sir,
Sir,
MR is widely audible.
and MR
That
normal
doesn't
is
make it
widely
severe.
audible.
That doesn't make it severe.
That doesn't indicate.
And cardiomegaly could be because of associated aortic regurgitation.
How often you see mild MS going in for thromboembolic manifestations?
Sir, actually patient had a history of mitral valve repair. So patient had a previous history of PND. So patient developed atrial fibrillation due to that episode. Actually patient previously had a MS, which is of severe fault.
But in hemiparesis is 9 years post-surgery.
See, the problem with such case presentations in rheumatic heart disease is that the child already knows the diagnosis by echo. So now once he has seen the echo and he knows that this is not severe MS, he will try to defend it. आप कितना भी कहिए कि भाई severe MS तो नहीं है, he will say no, there's no severe MS because he knows the echo findings.
Again,
So
that
that's the
severity of MR will also echo-wise severity of MR. So you're calling it severe MR.
Yes, so he
You are
knows the
telling
echo
those
findings. The
parasternal
problem is this.
pulsations are not related to a huge LA dilatation. That's begin with. Then you must go backwards. No, for MR severity again, the level of pulmonary hypertension again. Right. And then your this thing. It's always a problem. I do not deny there is a problem, but The whole issue is that you cannot have contrasting findings
Yes.
everywhere. Now here you have secondary TR is what you are saying is the provisional diagnosis. First you said there was no tracker.
TR, now you're saying TR.
Sir, maybe I was clinically not finding such evidence of TR, sir.
So how
So
do you?
Why are you calling it
JVP,
secondary TR?
sir, from JVP, sir, from JVP,
JVP, sir.
Important here is
What JVP
the
tells you what in the
provisional
setting of atrial fibrillation, how are you going to figure out your VY and all that you said is together, right? So why are you calling it secondary TR at all? You haven't heard anything to do with the TR, have you?
See, the point is you are trying to match your diagnosis with the echo findings. Your diagnosis should match your clinical findings. There can be mismatch between your diagnosis and echo findings. That's perfectly normal. But you
Yes.
cannot have mismatch between your clinical findings and diagnosis.
So I could be, clinically making a diagnosis of severe MS, but on the echo I might just have mild to moderate. So that doesn't reduce my impression. It doesn't get my impression down. But if on the other hand you stick to calling it mild MS, despite the fact that the patient has significant amount of pulmonary venous and pulmonary arterial hypertension, then that becomes a little difficult sort of correlate. So,
Okay.
instead of
Let
calling
us
it
move on
mild
to
MS,
investigations. Yeah.
okay. These are all teaching sessions. They're not actually
Yeah.
examinations. They're just trying to prepare you for your examination, and even that is not final. It just judge you by your presentations, whether you sort of have some idea or at least a good idea of your clinical situation. So
Another 5-6
try
minutes
to
left, sir.
match your diagnosis with your clinical findings. Don't try to match it with the echo which you already know.
Okay, go ahead now. Move to the
Go
next
ahead.
X-ray and
There's
ECG.
hardly any time.
I think we've
Sir?
done enough.
On
Is there
ECG,
anything to defend your diagnosis ECG wise or otherwise? Does this ECG help you in any way? What does it tell you? Just quickly tell us now. In terms
Sir,
of your
there is a atrial fibrillation, and axis is normal, and there is left ventricular hypertrophy, sir.
okay, fair enough. Is this patient on digoxin, you think, or no?
There is a patient is on digoxin, sir.
No, I'm saying I'm trying
The
to tell
ECG.
you on the ECG basis, is the patient on digoxin? This is what I'm asking. I'm not asking, is there
Any
something
STs?
that suggests that this patient could be?
Yes, sir.
Some of that STT is
STT
similar
is
to that is why I asked you.
ECG wise is
In
also
our
patient.
scenario, you're getting that ST depression with a T wave of configuration of that kind.
Yes, sir. Inverse. That's why I told you, sir.
Yeah,
Patient-
yeah. Very good. Very good. Next, go to the X-ray.
So this is the first X-ray is the PA view, and it is a overexposed film, sir. And there is a sternotomy suture, and on X-ray, sir, there is a cardiomegaly, and apex is LV type, and there is a on left border, sir, there is pulmonary bay is full, and right atrial enlargement, and
Did you mention the left atrium or no? Yeah.
Yes, left atrium also enlarged.
left atrium is also enlarged, sir.
Yeah, very big left atrium. Did you mention the sternal sutures?
Yes, sir. Mentioned.
You mentioned. But did you mention an important negative? Can you see any ring at the mitral level? You talked about mitral valve repair, right? So in repair, can you see, is it fluoroscopically visible or not? Some ring or anything like that? If they have done for pure mitral regurgitation, that time surgery, so to say. Okay.
And sir, there is a
failure when the X-ray
descending. Pardon, sir.
patient in right heart failure when the X-ray was taken. How do you identify features of right heart failure in the X-ray? A right heart congestion, at least.
That's why it's always good to start from the right border, go down, look at the SVC, look for the azygos, look for the right atrium. then you can answer what Dr. Sab has asked.
Yeah.
Always start from the border wise. Superior vena cava, as I goes, all prominent in heart failure. Right atrium prominent, left atrium prominent, LV apex, appendicular enlargement, main pulmonary artery enlarged, aortic knuckle not prominent. Then go to the pulmonary veins, then go to the pulmonary artery. Go systematically.
Okay.
So is the patient in right-sided failure?
Sir, SVC. Patient was having at the time of X-ray, yes, she was in right heart failure.
You can see.
Can we go to the echo because this says there's no time left?
Yeah. Please, sir.
You read the echo. Okay, it's not being played. These are only pictures. Go ahead. Quickly read the echo for us.
In the plaques and four chamber view, sir, LA and LV appears dilated, and aortic and mitral valve appears diseased. And with the color Doppler, we can see that there is a severe MR. And next slide.
Up. See, you should
If
say
there is any
appears
clinical
dilated
entity-
again is an ambiguity. LA is massively enlarged.
Dilated.
You should talk like that. You should give qualitative terms to it, Yeah, go
Okay.
ahead.
In the M mode, sir, LV and LA is dilated, and the mitral valve M mode image show atrial fibrillation. And
What is the LV dimension? Mr. LV is dilated.
LV size, sir, LV size is 51 mm.
LV is normal. It's not dilated.
And 4.3 or 43 millimeter, 31 millimeter.
That is wrongly written, sir.
It's wrongly written, is it?
Yes, yes.
How can it be wrongly written? It can't be wrong. Whatever measurement you have taken, it will display. You might have wrongly taken, but it will not be wrongly written.
Yeah, unless you wrote and paste, you pasted an image over there for the values.
That is different, yes. Next.
What about the LV wall thickness? It's high norm. It's 1.1 or thereabouts, right? Yeah. Looks. What I'm trying to only ask of you is there associated aortic stenosis at all there on the basis of that M mode? Of course, you'll have your color to
Go back. Go back one slide. Yes. Tell us about, is it thick?
The aortic valve, sir.
No. Wall.
Left ventricular wall.
Left and LB wall, sir.
Septum is 12 and posterior wall is 11.
Yes.
So there is a mild hypertrophy.
Okay, nice.
Okay.
Go, move forward. Yeah, now you can comment.
On the, sir, there is a color Doppler showing the moderate aortic regurgitation, and again, sir, aorta is normal size, mildly dilated, and aortic valve is thickened and calcified.
Why do you have to take so many? In what situations do you want to take so many measurements in the aorta region? One at the annulus, the other is at the sinus level, one is the sinotubular region. Why do you want to?
If patient is planned for aortic valve replacement, then we should take all these measurements.
Okay,
More relevant for a bicuspid aortic valve or for Marfan's, right? AR of the Marfan's. Where you are thinking also in terms
aortopathy, where aortopathy is.
Time is almost up.
Yeah, chalo, tell us what is it next.
Just last couple of questions and finish off.
So what will you do for this patient? Now, what is your, on the basis of the echo, what's the diagnosis on the basis of echo?
What is the gradient across the aortic valve?
Gradient, sir. Across the aortic valve, sir, it was mean gradient was 28.
Okay.
So what was the murmur, harsh murmur about?
That was the functional ejection systolic murmur. That was functional ejection systolic murmur, sir. Due
With a
to
moderate aortic regurgitation, no wide pulse pressure, you expect that much of functionality across aortic valve. The aortic valve does appear to be thick to me. The valve is thick. Measure the area across it from the short axis view.
no, sir. I did not.
Okay, let's see. Let's hear your final diagnosis on the echo. What was your final? Okay.
Sir, rheumatic heart disease with final, sir. There is the PhD, AR PhD is 250, sir. And this is the suprasternal view showing the third slide is the suprasternal view showing the diastolic
Just tell us the diagnosis on the echo.
diagnosis. It is RSD with severe MR with moderate severe MR, mild MS, and moderate AR.
Okay. So that is what you were trying to tell us clinically also. So this is what you have. So now, Dr. Pinukas, Dr. Praful's,
how will you
Check, what
manage
do you
this
manage?
patient now?
How
Tell
do you
me
manage?
that. Chalo,
Sir.
give me last 2 minutes for your
Yes.
Sir,
yes. How
first
do you
thing,
manage?
minutes to answer.
I will give the stabilize the patient with diuretics and control the
Okay,
heart
she's
rate.
already stabilized.
Huh.
Yes, will you give vasodilators? You won't give vasodilators.
Since the AR is
You said severe MR, severe moderate AR, and hardly any stenotic lesion anywhere. So would you give this patient just diuretics and digitalis, or will you give some vasodilators? Plus, your clinical estimation wise, LV was mildly dysfunctional. So will you give vasodilators or not? Yes or no?
Sir, vasodilator will be effective in this patient, sir.
You will give. So say yes,
Yes,
or
sir.
no.
Yes.
That's what
Yes.
it is taking
Yes,
so
sir, it
long
is-
to
it
answer
is
that.
useful.
I also gave you the hint. There is no stenotic lesions anywhere.
Yeah.
Yes, sir.
Okay. Okay. Then okay. The Dr. Narayan has told you patient is well stabilized, medications done, everything done. She got admitted now this time with a heart failure with you. Now what will you do for this patient?
we will go for the valve replacement.
Sir, we go for double wall.
Do
Sorry?
a double valve replacement.
Post a redo patient with a double valve replacement, what do you expect the results to be? What are the why I am as a family worried she will not come out of the surgery? Will she or will she not? And what is the expected mortality?
So expected mortality of DVR is 9.2%.
Don't say DVR in this patient. She is a redo. She's
In-
got now she is going to go for a surgery again.
In
For
these patients, it will be more than normal DVR. It will more than in the tune of 10 to 20% mortality, 10 to 15% mortality.
So it is important to figure out how much is that aortic valve disease. She goes in today, then she will definitely require a double valve, and her risk is extremely high. So in our kind of a setup, unless the surgeon gives you a this thing that yes, this is still low risk for me, I can still operate on this and deliver. Again, now she's going to receive in the face of a prior stroke a double valve, which is necessarily at her age going to be double valve mechanical replacement, isn't it?
Yes.
Again, that's why that INR history, going back to INR, again, because of atrial fibrillation, anyway, she's going to require anticoagulation.
Praful, I think.
Now, what will you do for her? One last question. Will you operate? Will you go medical like that only? Or what would you do? One last answer. Yes for surgery, no for surgery.
So we will go
The
for the
patient-
definitive repair since patient is 36-year-old female.
And LV dysfunction, sir.
There is
Actually,
a
double
LV
biventricular dysfunction. So mortality is on medical management is high. So we anyway go to double valve replacement, sir.
Double wall replacement. That's right. Okay. Fine. I'm purposely trying to give you the negative aspects of it. But as you have to answer like a consultant. In spite of that, I'll say a good center, we will be able to operate upon her and we'll make a difference to her outcome. That's how it is. Good. चलो
Okay.
संतनु बुआ भी मारेगा अपने को, जल्दी अगला करो. I am done. I am not supposed to do the whole last.
You have taken up another 6 minutes extra. Anyway,
Thank you. Thank
that's
you.
a good discussion. Jignesh, next is perhaps Anand Tagore.
Yes, sir.
You please bring the next set of examiners and
Sir, I've admitted them in group.
yeah, and bring the students to share the screen, or you share.
Sir, they are sharing it. We have kept as a backup.
Fine.